Hello, my name is Luciana Lolich, and I have worked with Kathleen Lynch on a project entitled Potential Inequalities in Palliative Care Services. In the past few years, choice has become a key quality indicator in palliative care services, and we were interested in this project in examining how a discourse on choice can contribute to potential inequalities in palliative care, because it fails to take into account structural inequalities, body decline, and human relationality. So in the past few years, as I said, choice has become an important factor in terms of measuring the quality of palliative care services. And especially in Ireland, choice has been equated with choosing your place of care and death. And home death has become a proxy for good quality care, without maybe examining the wider implications of this. Our interest, as I was saying, was mainly in three key areas. The first one is structural inequalities. So we were interested to see how people's positioned within society affect their abilities to make choices, and how then this affects their access to palliative care services. So for example, people's cultural preferences, people's economic resources. Research has shown that people with higher economic resources are more likely to die at home, and they're also more comfortable in discussing their preferences with doctors, because their cultural backgrounds are more similar to those of their physicians. Second, we were interested in looking at body decline and how this affects people's ability to make choices. Obviously, people at the end of life are in a very particular point of their life trajectory, so they may be cognitively impaired or emotionally impaired to make the best choices for them. And third, we were interested to explore human relationality in terms of the patient, but also of carers. So in terms of being able to have a home death and a good death at home, you need only not economic resources, but you also need affective resources, people who will care for you. Our research has shown that mostly carers, whether they're paid or unpaid, are mostly women. And when they're unpaid, and especially maybe when they belong to the private sector, most of these women are also migrant women. So it's important to consider the relationality of these carers and to what extent they also have a choice in terms of what they're doing and the care they're providing. So our conclusion was really that when choice or discourses in choice are put forward, it's important to examine the wider implications of choice, and maybe to what extent compassion and good quality of care might be better than choice at the end of life.
One quarter of the population in Ireland will experience mental health problems during their lifetime. 1 in 5 of this population will experience serious mental illness. In the general population, our life expectancy is increasing. However, with people who have experienced serious mental illness, the life expectancy is decreasing by up to 30 years. Previous research indicates that access to healthcare facilities for people with serious mental illness is compromised by social inequalities. This study set out to see if such inequalities exist in access to palliative care services for this group of people. This was a mixed method study and involved an All-Ireland survey of GPs and also an All-Republic of Ireland survey of psychiatrists. Also, we interviewed a number of psychiatrists who had taken part in the study. All of this information has informed the outcome that I'm going to talk about. 35% of the GPs who responded to the questionnaire and 55% of the psychiatrists who responded to the questionnaire reported that they had people attending their clinics with serious mental illness and also palliative care needs. 80% of GPs and psychiatrists who responded to the survey indicated that people with serious mental illness attending their practice had difficulty reporting physical health care problems. Over 80% of GPs and 90% of psychiatrists indicated that people with a serious mental health problem are more likely to have their physical health problems overlooked in general healthcare services. In this study, the physical healthcare system was portrayed as resistant to accepting people with serious mental illness into the acute services. All psychiatrists interviewed in the qualitative interviews discussed how complex it was to manage both serious mental health problems and physical health problems of their patients. According to the psychiatrists interviewed in this study, structures to support the provision of this complex care to people with serious mental illness and healthcare needs is either underdeveloped or lacking in our Irish healthcare services. Therefore, much work is needed to be done in this area. This study clearly indicates issues relating to social justice and inequality for people with serious mental illness. There is a general consensus from this study that people with serious mental illness had reduced access to physical health care services in comparison to other citizens in Ireland.
My name is Fiona Hurley. I'm a PhD student. My PhD study is entitled An Exploration of Access, Decision-Making and Experiences of Palliative Care Services for Families of Children with Non-Malignant Life-Limiting Conditions. Children with non-malignant life-limiting conditions are the largest cohort of children who are accessing and utilising palliative care services. The numbers of children with non-malignant life-limiting conditions are increasing due to medical and technological advances. Hence, it is important to understand the unique experiences of parents who are currently caring for their child with a non-malignant life-limiting condition and the experiences of healthcare professionals who are providing care to these children. Many of the studies that were previously undertaken focused on the experiences of bereaved parents. This study uniquely looked at the experience of parents who are currently caring for their child with non-malignant life-limiting conditions and the challenges they face on a day-to-day basis. 23 parents were interviewed across the island of Ireland from both north and south. 3 themes are emerging from the parent findings. The first theme is called Starting Out in Haziness. This theme represented the time period from diagnosis or recognition of a life-limiting conditions when parents and families began to start out on this unknown journey filled with emotional turmoil. Theme 2, Managing an Unexpected Life, captured the time period in the parents' journey when the emotional turmoil began to settle and parents began to respond to the emotional and practical chaos in their lives. The third theme that emerged was that the ship is going to go down. The ship is going to go down represented the experiences of parents who are living with the knowledge that their child is going to die, but not knowing when this was likely to occur.
Heart failure is a serious life-limiting condition that presents many challenges. Globally, there are over 26 million people who are living with advanced heart failure, and this number is set to rise as people are living longer. But what about the carers? Evidence would show that these carers are usually of similar age and profile. Yet what normally happens is that they prioritise the needs of their loved one and their partner over their own needs, and this often means that they put their own life on hold. But this can cause problems, not only for their physical health, but also for their emotional and psychological health. For example, anxiety and depression, as they cope with the reality and the burden of caring for their loved one with advanced heart failure. My name is Sonia McIlfatrick, and I'm a Professor of Nursing at Ulster University. And alongside my colleagues, Professor Donna Fitzsimons and Dr. Leanne Docherty, we undertook a study that aimed to look at the palliative care support needs of carers of people living with advanced heart failure. This involved 2 stages of a study in which we undertook a large survey with patients and carers across the island of Ireland and the UK. And then we also undertook interviews where we listened to both current and bereaved carers' stories to try to understand their experience of caring for someone living with advanced heart failure. We found that many of the carers felt unprepared for their role and had unmet needs, and they had concerns about the future and the future care needs of the patient. They also felt frustrated with the healthcare system and described their experience almost like an emotional roller coaster, with many ups and downs as the disease journey of the person with heart failure changed. Whilst many of the carers were happy to undertake this role, they also experienced many problems, and it is important that we understand these issues and concerns so that we can help them to feel better equipped and able to undertake their role. We would like to acknowledge and thank all the patients and caregivers who give of their time and shared their stories.
So the aim of the study was to understand the health status of people with an intellectual disability, the types of illnesses that this population had as they reach end of life, the levels of multiple morbidity and the types of disease patterns in this population. And particularly to understand the experiences of staff who were supporting this population at the end of their lives. It was interesting that about 50% of this population were reported to be ill for less than 6 months prior to death, with 25% of them just being ill for approximately 1 month. And there was often a lack of preparedness around planning for end of life or planning for the eventuality that somebody was going to die. And this often resulted in decisions and being made which were often charged by high emotion, and this was often very stressful for staff caregivers. Assessing and management of pain was often very difficult for staff, and this was quite complex because many people with an intellectual disability were not able to verbally indicate that they had pain. Staff were heavily reliant on non-verbal cues in order to ascertain A, if the person had pain, and B, if the treatments were actually effective for that pain. Now, this was often emotionally draining and taxing for staff who were trying to provide care. And having support of the palliative care team was very comforting and reassuring to staff carers, and resulted in better management of pain and other symptoms. Supporting the person of the final journey of life and who are dying was described by staff as a privilege, but it can be also emotionally taxing for staff, particularly if the structures and proper supports are not available. Staff played a very fundamental role in advocating for services. Unfortunately, many staff reported that they spent a lot of time really fighting for services, trying to get the right supports for the individual that they were caring for, and really fighting to be listened to. There was inequity in the availability of palliative care services across the country. Some parts of the country, staff could access this type of support in a timely manner when they required it, and for other areas of the country, this simply just wasn't available. And this was very stressful for staff at a very vulnerable time in the person's life, and at a time often when they felt very alone and inadequately prepared to provide the level of care and support that the individual required. So it is very important that we have proper structures and supports put in place, that we have formal training available to staff to support them and assist them in this role, as well as ensuring that there are good links, formal links formed with palliative care services to provide this additional support to the person with an intellectual disability who is dying, and supporting staff who are caring for the person during this final journey.